بسم الله الرحمن الرحيم والحمد لله رب العالمين والصلاة والسلام على سيدنا محمد وعلى آله وصحبه أجمعين. Good evening everybody and welcome to our webinar today by the Saudi Clinical Pharmacy Group under the umbrella of the Saudi Heart Association. We would like to thank also Novartis for the sponsorship of such a webinar. Our webinar today will be an exclusive one. I will talk about the Center of Excellence of Heart Failure in Saudi Arabia in King Khalid University Hospital under King Fahd Cardiac Center. It's a pleasure to have our very important and eminent speakers, the heroes of this program in the center. And it's always a pleasure to introduce my colleague, Dr. Usama Al-Miqbil. He is a cardiology consultant, heart failure specialist. It's a pleasure, Dr. Usama, to introduce you as the head of the heart failure unit now in the University Hospital. And the screen is yours to start your part is introducing our colleagues in the program and running the show with our eminent speakers.
Thanks so much, Dr. Fakhar, and thanks everyone for joining us on a Friday evening during Ramadan. كل عام بخير everyone. تقبل الله منا منكم طاعاتكم وصلاتكم يا رب العالمين. It gives me a great pleasure to introduce the first speaker, Dr. Faiz Al-Sha'ir. He doesn't need an introduction. He's a colleague and a dear friend, consultant cardiologist and associate professor in medicine and heart failure. And he's going to present to us updates in the management of heart failure with reduced ejection fraction.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullah. I would like to thank the Saudi Heart Association and the Novartis Pharmaceutical Company and also King Fahd Cardiac Center in King Saud University and all the team of heart failure. And I would like to thank the audience for coming and attending this webinar. This is my task is to just discuss with you and give you an update management of heart failure with reduced ejection fraction. Okay, so we have here that the heart failure affects more than 60 million people worldwide, and 50% of them will die within 5 years. And we know that the new cases of America, 1 million new cases per year diagnosed with heart failure, and the lifetime heart failure risk is about 20 to 45%. And 1 year mortality in Canada is about 20%, with 1 year hospitalization is about 50%. And the main reason for heart failure cardiovascular mortality is the rehospitalization. And we know that each admission costs around $25,000, and the projected cost will be about 127% in 2030. And the global heart failure cost was reaching up to 108 billion in 2012. So this is a review article, and it is a decision, expert consensus decision pathway update of the 2017. And this will answer the 10 pivotal issues about heart failure with reduced ejection fraction. And I encourage all of you to go through this one. I will try to just shed some light on most important points in that paper. And the agenda is I want to talk about the new definitions, the new stages, the definition of shock, and the heart failure risk trajectories, and need to improve HFrEF, some guidelines of American College of Cardiology and Canadian Heart Failure Group guidelines, also essential skills for heart failure team and adherence cost or palliative care. All this included in that paper. So what is the universal definition and the new definition? This is a brand new, is 2021, and this is current or prior symptoms of heart failure caused by structural or functional cardiac abnormality, and this is include one of the following: ejection fraction less than 50, abnormal cardiac chamber enlargement, EA prime more than 15, moderate to severe ventricular hypertrophy, moderate to severe valvular obstruction, and also there should be one of the following: either natriuretic peptide is elevated, NT-proBNP in chronic heart failure patients more than 125, and in acute heart failure more than 300, and BNP is about more than 35 in acute failure in chronic chronic patients and more than 100 in acute heart failure. There's also the presence of extra of the cardiogenic pulmonary or systemic congestion, and this is proven by chest X-ray or by echo filling pressure or by right heart catheterization at rest or with exercise. So we have a different trajectory of heart failure. We have de novo heart failure, new onset heart failure, newly diagnosed, no former history of heart failure, and we have worsening of heart failure. Worsening, what is the criteria of worsening? Worsening of symptom and sign, and the indication of IV medications, and also hospitalization. And then improving heart failure, those heart failure who are improving their symptom and sign. And then we didn't use now stable heart failure, because heart failure is not stable anymore. We call it persistent heart failure. Persistent heart failure with ongoing symptom and sign. And also we don't use recovered heart failure. We use the remission heart failure in remission, because this patient had the resolution of sign and symptom, and also might have improvement of cardiac function, but don't stop the medication, because if you stop the medication, the LV dysfunction will return back again. This is an algorithm which was all known to all of us as stages of heart failure, stage A, B, C, and D, and what are the characteristics of each stage and how to treat it. But these stages are modified now into a stage A, which is stage heart failure at risk. There is no biomarker, no structural disease, only risk factor. And the stage B, which is pre-heart failure, and pre-heart failure is easy to convey to the patient, to tell him that you are pre-heart failure than stage B. This is you have to have one of the following: structural abnormality, or natriuretic peptide elevation, or troponin, or abnormal cardiac function, systolic or diastolic. Heart failure stage C, as we know, the symptomatic one, and heart failure remission and persistent heart failure. And stage D is now named as advanced heart failure, not anymore refractory heart failure. And this is if the patient is not responding to medications and the persistent symptoms in spite of guideline-directed medical therapy. So this is a continuum of heart failure development. How to treat these patients? Healthy patients, we go for primordial prevention, and stage B, this is the one to treat it. And what to treat the specific cause, specific risk factor, and treat the etiology in order to reverse the remodeling and neurohormonal antagonists. And at class C, you go for the treatment of symptoms, the reversal of remodeling and the neurohormonal antagonists also. So we finish the classification of the ejection fraction. Now we know that less than 40 is HFrEF, or HFmrEF, which is from 41 to 49, and heart failure was preserved ejection fraction more than 50. And then we have an HFmBEF, which is improved ejection fraction, and this is the one if the patient ejection fraction improved by 10%. If it is below 40, then becomes above 40. We call it improved. This is a new term. But I believe that this classification will, by the next year, it will be changing totally to more than 50 and less than 50. Then clinically, we need to know our patient is they are congested or perfused, and congested either wet or dry, or cold and warm. And this is only for right side as well as for left side, and if it is biventricular or no. What is worsening heart failure? As we mentioned, worsening of the symptoms and hospitalization. And in this real-world trial, it was found that 1 in 6 patients, they will have a deterioration of their function within 18 months. And with each deterioration, there will be more the deterioration of this cardiac function until downhill to death. And with each cycle, your patient need to present to the hospital or to the clinic and intensify the medication, then additional follow-ups and additional cost. So we know that about 50% of our heart failure patients, they readmitted within 30 days, and then with time they go have a repeated admission, and there is increased number of readmission the way from the first dose. From the first admission, and with the admission rehospitalization, we know that the more the number of rehospitalizations, the more the reduced survival and more complications. Then we come with cardiogenic shock here, stages of heart failure, stage A, B, C, and D, with classes, New York Heart Association. Then we go to the intermax status, and this they have different 7 classes of intermax status. The patients had walking wounded and housebound, still at home, that cannot go outside, or frequent rehospitalization with inotropic dependent and the sliding on inotrope. Instead of inotrope, they deteriorate and then crash and burn, and this is to go for further advanced heart failure workup. Then we come to the definition of the shock stage. We have a shock stage, stage A, which is the patient has neither hypotension, no hypoperfusion, and stage B, which is the beginning, hypotension without hypoperfusion, and class C is hypoperfusion without deterioration, and then hypoperfusion with deterioration, and hypoperfusion with resistance. And you know, the more the class you go to E class, the more the mortality in hospital, reaching up to 70% of mortality of those patients. And we know that heart failure syndrome and heart failure doesn't come alone, come with friends. It is a social disease, like to have a lot of comorbidity. We have 4 or 6 comorbidities associated, and the more the association of the comorbidities, the more the worse the worsening of heart failure. And we know the mortality of the comorbidity like hypertension, coronary artery disease, atrial fibrillation, etc. So why this patient will get worse on prognosis? Because of the adverse remodeling, cardiorenal, cardiohepatorenal, cardiovasculorenal, and we have also associated comorbidities and causal factor not corrected. Also high residual risk not medicated and not dealt with, and poor adherence to the guideline-directed medical therapy. This slide is a little bit busy, but I want to tell you that we have 3 ways of management of heart failure. The first method is the conventional way, which is the stepwise approach. Go by one medication, then it increasing gradually, titrated gradually to reach the maximum, then start the other medication and going to the maximum. And this will take about 3 to 6 months. But the a new method is the comprehensive way. Start a small dose of each, and when you compare this one to the conventional method, it is more effective, and there is more reduction of the complications and mortality and morbidity. And the newer one is the condensed way, is to start a small dose and titrate up, reaching up to the maximum tolerated medical guideline-directed therapy within 4 weeks. Within 4 weeks. So with each stage of titration, you have to check your patient to do the BNB, ECG, chest X-ray, clinical examination, and within 1 to 2 weeks of each change in the medication and each titration. And if the patient lack of response and loss of intensity, so the patient will tell you, I need help. So you need help by referring him to advanced heart failure program, and this is acronym indicating that this patient should be on inotropes. He was NOHA class 3 or 4 in the organ damage, ejection fraction less than 35, defibrillator, hospitalization more than 1, or edema despite diuretics, and low blood pressure or not responding to the medication. Then this paper also discussed a very important 10-point pivotal point to discuss. First of all, we know that our management is starting by initiating and then adding or switching, and treatment, and also we say comprehensive or conventional or comprehensive or condensed way, and then we go with titration. Titration, we have each drug has its own duration. There is some drug need 3-step titration, and there is one medication only 1-step titration. And then we go to referral to heart failure specialist, and what is the indication for referral to heart failure specialist, and how to refer the patient. What is the method of referral, and what should be the issues in the referral form. And then care coordination of heart failure team to do everyone is doing his job. And then we look at the adherence and the cause of non-adherence for medication, and the specific patient cohort dealing with the frail patient, elderly patients, or African American. And then how to manage heart failure by 12 pathological trajectories. And then look at the comorbidities, cardiovascular and non-cardiovascular, and the 7 principles for the going for hospice or palliative care. This is a line of treatment of heart failure. When you go for RAS system activation, ACE inhibitor, ARB, aldosterone, and sympathetic nervous system inhibition by giving beta blocker and titrate up gradually. And this usually we do beta blocker when the patient is eupholemic, natriuretic and other neprilysin inhibitor plus the ARNI, plus the angiotensin 2 receptor blocker, using of SGLT2, and we have two important trials, the DABA-HF and the Emperor reduced the trial with have a very important clinical benefit. And in patients with African American special patients or patients who are persistently in stage in NIA class 4, we go for hydralazine isosorbide nitrate as an add-on, and it is also a positive drug. If your patient heart rate is still more than 70, after maximum tolerated beta blocker, you can go for ivabradine with titrate up gradually from 2.5 to 5 to 7.5, and also relieve congestion by diuretic, increase the dose of diuretic, looking at the braking phenomena and resistant diuretic resistance, and how to combine the diuresis together, and up to ultrafiltration. And ventricular arrhythmia with no ICD is decreasing the incidence of sudden cardiac death only, but has no effect on remodeling and no effect on symptoms. And the cardiac resynchronization therapy decrease the symptom, reverse the remodeling, and decrease on sudden cardiac death. The mitral regurgitation, we have mitral clip or the CAP trial, and going for surgical and percutaneous mitral valve repair. And this is on top of maximum medical therapy in order to get the results, a good result. And then we go for the rehabilitation program, aerobic exercise training. With this is pathophysiology, we have to antagonize the four mechanisms: RAS system, aldosterone, the sodium, the vasopressin, the sympathetic overflow, sympathetic antagonist. And this is shown that where drug works in the brain or in the kidney or in the cardiac, and decrease the hypertrophy or remodeling. And we know that our classes, our groups, ACE inhibitor, beta blocker, ARB, MRAs, and ARNI. This is the drug which has a clinical benefit and decrease the mortality. Then we come to the Pioneer trial, which is this one after paradigm. This Pioneer, you can start the patients in de novo patient on while he's admitted in the hospital before discharge. After stabilization, you start him in the sacubitril valsartan, and after stabilization, mainly it means that he off diuretics, IV diuretics, and off IV inotropes. Then before discharge, you can start your medication and go for titration up. And this was found to have by the PROOF-HF trial that there is an important reverse remodeling, especially if the patient started de novo from the start without shifting from ACE inhibitor to ARNI, and there is a reduction of 12% improvement in ejection fraction within 1 year. This is the guideline. I just showed to you ESCC guideline and how it was built in ACE inhibitor, beta blocker, and then MRA. Then at the third stage is ARNI. And this is the 2017 guideline. The ARNI become at the same level of the MRAs, but nowadays the guidelines, the ACC guideline updated, it is all in parallel. You start ACE inhibitor as ARNI first, and if not ACE inhibitor or ARB, beta blocker and diuretic, and then in parallel, since you can add according to the situation. If the patient had the eGFR less than 30, the same criteria, and creatine less than 2.5 or in male, and in female less than 2, or potassium less than 5, go add aldosterone antagonist. And if the patient had NIA class 3 and 4, you can still add dapagliflozin if the eGFR more than 30. And patient with persistent symptom and congestion, you can titrate up the diuretics. Or patient who had black patient, African American, they can increase hydralazine isosorbide dinitrate. And those who had tachycardia, you can add ivabradine. ARNI, how to go for ARNI, and this is very important. Just start by 50, then go to 100, then go to 200. Some patients, they can tolerate 100 from the start if they were in good dose of ACE inhibitor and ARB more than 110 in Referral or more than 160 milligram. And then with each step, you have to look at your blood pressure, the labs, kidney function, and the electrolyte. ACE inhibitor, if it is contraindicated early or have some side effect, you can go titrate up, and the beta blocker go for every 2 weeks step until you reach. Diuretics, you can go up and can combine diuretics. You can change diuretic. You can add thiazide. You can go for ultrafiltration. Aldosterone antagonist. This is when you started, you have to see the patient after 3 days, then after 7 days, and every month. For the first 3 months, then with each follow-up, checking the kidney function and the blood pressure and pulse. SGLT2, it is only one-step titration, which is good, but one dose given and just follow up. And this patient should be creatine clearance more than 30. Hydralazine dinitrate, as I mentioned, you can add it, and ivabradine also. There is 3-step approach here: 2.5 BID up to 5 BID, then 7.5 BID. If the heart rate goes more than 70, you can go titrate up. If it is less than 50, you have to go down and keep the patient on 2.5 milligram BID. This is the Canadian guideline, just recent, more recent than the American. And this is starting the 4 pillars in the same time. And if this patient had an atrial fibrillation, add digoxin. If the patient had sinus rhythm and his heart rate, sinus rhythm or intermittent paroxysmal AFib, you can start ivabradine. And then a patient who had repeated rehospitalization and heart and high risk group, you can start the Versigouet orally, and also you can add hydralazine dinitrate in a special group of patients. And this is the 4 pillars for heart failure. Actually, there are not 4. There is another 4 which is not mentioned here: hydralazine azurbide and the Versigouet and omecamtiv mecarbil and the CRT. Also, they are considered as a pillar for heart failure. And we have the clinical trials effect of each of all these drugs, 28% to 17%, 30%, and this is persistently over years, over 2 years. There is a reduction in the mortality. And when they compare the conventional way of management to comparison with comprehensive way of management, it will show that this comprehensive way of management add 6.3 years to life. This is very good. So prolonged life. And also, sure, no, we don't want prolonged life only. We need more quality of life, and we can assess by the other questionnaires. Then the patient, the African American, they have a special deal, and the older patient, you have to start low, go slow, and because they have polypharmacy and they have a lot of comorbidities and frail patients, you have to look them and give them more frequent visits. That's not all. There is still unmet need for this. You know, here in a patient with in the paradigm HF trial, there is still residual risk. Yeah, the ARNI is reducing the mortality, but there is still about 21% patient who might have a mortality or rehospitalization. And dapagliflozin, also there is still residual risk, about 16%. These patients still they die. That's why we didn't mention stable heart failure at all. We call persistent heart failure. And then the empagliflozin, also the same story. Then patients come to your hospital. What you will do, either improving, then go for the optimization phase, the early discharge phase, then transition to outpatient follow-up. And patient might go persistently the same or might get worse. And that's why he has to go for the referral to heart failure program. New onset heart failure should be referred to heart failure program. Patients with high risk group to 2 emergency visits, readmission, and cannot tolerate the guideline medication and persistently elevated BNP, you should refer them. Patient with ejection fraction less than 35, despite of guideline directed medical therapy more than 3 months, you can go for ICD, for CRT or whatever. You can also rule out ischemic heart disease by revascularization, valvular heart disease, myocarditis, go for MRI to diagnose like myelinosis, restrictive cardiomyopathy, or Chagas disease, and annual review by the heart failure specialist. And some of them, they can go for studies. Here, what is the form of referral? When you refer a patient, you have to have mentioned, is this patient HFpEF or HFrEF? What is his NIA class? What is his recent documentation of ejection fraction. What is his medication used? What is his what do you want from the heart failure program to add? And if there is any side allergy or side effect or adverse effect or whatever. And also you have to contact the pharmacist in order to arrange for the medications. Essential skills for heart failure. The heart failure team, they diagnose and monitor and prescribe, titrate, educate the caregiver and the patient, lifestyle prescription, psychological and social support, palliative end-of-life care, coordination of cares with other comorbidities. And we have to have what we call it as infra baseline structure, like electronic health record. We have to have wearable activity monitors, smartphones, and implantable devices or wearable devices. And then we look for the adherence. We look for the why there is no non-adherence, because of side effect, complex regimen, distractions, rumor from the WhatsApp, don't use this medication, use fat, use like this, lack of clarity of going treating the disease, not treating the symptoms. So the cost of care, you have to just consider insurance, also the pricing of the drugs, and the pharmacist, social worker, and patient navigator, and to have like a complementary program for that. And the last slide here is how to integrate for palliative care. 7 steps for palliative care. If you have palliative care, you have to reduce suffering, you have to treat symptoms, symptom palliation, you have to ameliorate refractory heart failure symptom, to think through the benefit and burden of each step you do, and share decision making with the families, with the physician. If the patient cannot live more than 1 year, why you put an ICRT or ICD? And also attention to calibrate expectation and guideline timely decision. And then what transition from do everything to comfort only hospice. So just do the minimum for this type of patients and hospice care or palliative care. So at the end, I will try to say that a mediocre physician treat advanced disease, a good physician treat the disease itself, and a great physician who prevent the disease. And we should all aim to be a great physician, and the prevention is better than cure. Thank you, and sorry for just more time. I take more time because this is a very good review article. Thank you.
Thank you very much, Dr. Faiz. It's a great talk. The most updated information has been presented now. It's a pleasure to have Dr. Osama Al-Mikbil in his next talk. Dr. Osama Al-Mikbil, as I just said before, but because we have more participants joining, he is the head of the heart failure unit in King Saud University, King Fahd Cardiac Center. He is a consultant cardiologist, and he is also specialized in heart failure and cardio-onco therapy. So please, no further talk. I'll just introduce the screen to Dr. Osama to have our next speech, which I'm sure would be a very enjoyable one.
Thanks so much, Dr. Fakhr, again for this nice introduction. So I'm going to basically continue from what Dr. Faiz finished. So we have an update about how to manage patient heart failure. But as he mentioned at the end, there is a lot of challenges on implementing these therapies, especially new therapies. And I'm going to focus on the role of multidisciplinary team approach and our experience at King Fahd Cardiac Center. So initially, first, I'm going to talk about the role of heart function clinics, then touch base on our experience and finish with case presentation and some future directions. Dr. Faiz clearly illustrated to you the heart failure burden. I'm just going to focus on local data from the heart registry database led by Professor Khalid Al-Habib and colleagues. And as you can see, heart failure is associated with high mortality in Saudi population with up to 25% all-cause mortality at 3 years. And our patients have more cardiac risk factors and likely to present at younger age. And major challenges in managing patients with heart failure from the heart registry include non-compliance to heart failure therapy in up to 20%, and non-compliance to diet in 25%, with 1 year readmission rate up to 40%. Comparing the heart data registry to international data registry, you can see our populations are younger, 60 compared to 75 in that here from US. Diabetes more prevalent in our population, reaching up to 60 compared to 40 in other population. And length of stay is longer than other international registers. This is the comorbidities. Our populations have more hypertension and diabetes and dyslipidemia. And all-cause mortality is high, reaching up to 25% at 3 years. Internationally, also there is gaps. I mean, what Dr. Faiz mentioned, about the guideline-directed medical therapy is good, but when you come to registry and day-to-day practice, this is from the CHAB HF registry. You can see in the green, this is the percentage of population that's from heart failure patients with HFrEF, they are taking the guideline-directed medical therapy. And in regards with ACE inhibitors, only 60% receiving either ACE or ARBs, and only 12% receiving ARNI. When it comes to either ACE, ARB, or ARNI, only 70% are taking this class of medication. And beta blocker is more or less the same, around 70, and MRA is around 33%. And even when they take this medication, you can see our target is the blue pie, and only around 17%, 14 here, and 16 here are taking the target dose. And the red is bad. These are the patients that are taking the medication, but not at the optimal target dosage. So what are the reasons for lack of uptitration? I listed some of the reasons I think are barriers for lack of medication intensification. One is lost in transition from the inpatient to outpatient setting. Most patients will be, started on ACE inhibitors, and follow-up will be in 6 months in a general cardiology clinic. Second is the perception, as Dr. Faiz mentioned, that NYHA class 2, they are stable. And most of our population don't report symptoms. When you ask them, I'm fine, alhamdulillah. But when you dig more into the history, you will find them, they are either minimizing their activity, or they are symptomatic when they go upstairs or go to the mosque and such. Also, in our population, there is a huge unwillingness of the patients to take medication. And even when they take the medication, their perception is to decrease the dose, not to uptitrate them. And whenever you see the patient in the clinic and you say, okay, I'm going to increase the dose, first reaction will say, what? No, I want less medication, not to increase the dose. But there's a lot of lack of education to our population in terms of optimal medical therapy and target dosage. Also, physicians are worried about adverse events and risk of hyperkalemia and renal failure. And as Dr. Faiz mentioned, there's a new paradigm shift in managing heart failure patients with the 4 pillars, including the new kids and block SGLT inhibitors. All these findings illustrate, we really need a multidisciplinary heart function clinics to be able to improve patient compliance and their outcome. And this is a meta-analysis of 29 trials examining the effect of multidisciplinary programs. And as you can see, using this, from this meta-analysis, there's a 25% reduction in mortality, just applying a multidisciplinary care for such a patient. And decrease in hospitalization by 26, and decrease all-cause hospitalization by also 20%. This was emphasized in the guidelines with the class 1 indication for multidisciplinary heart failure management program is recommended for patients at risk for hospital readmission to facilitate implementation of GDMT and to address the different barriers to behavior changes and to reduce the risk of subsequent rehospitalization, which carries poor prognosis. Also, scheduling an early follow-up visit within 7 to 14 days is recommended. And as you know, in the daily practice with busy clinics, you're really hard to get a visit with a physician within 7 days. Also, the European Society of Cardiology recommendation, class 1, class of evidence A for implementing such multidisciplinary team. There is a position statement by the the European Society of Cardiology Heart Failure Association for the standard of delivering such care. And by providing such care, you will be able to improve patients' outcome. What are the essential ingredients for such a multidisciplinary team? You really need to have a heart failure cardiologist, and we're blessed to have 2 cardiologists and a suburb and super resident who's managing patients with us. And we have heart failure nurse specialist, a pharmacist, and a dietitian or educator, and a space. And that space doesn't have to be a physical space, but it can be a virtual space, especially in the COVID-19 era. And with such, you can implement the heart function clinic. And these are the data since the beginning of the program by Dr. Walid Al-Habib in 2017. We have seen more than 1,000 patients. And as you can see, this highlights some of the challenges we are facing. Majority of our patients, more than around 44%, are more than 60 years of age. Most of them are HFrEF, but we see some HFpEF patients. And in line with the heart registry database, we really have more prevalence of diabetes and hypertension and CKD in our population. We are serving mostly from Riyadh, but we have outreach to other patients from outside Riyadh. What are the goals for heart function clinic? This was mentioned by Dr. Faiz, but briefly, education, counseling the patients about restriction and medication compliance, and self-monitoring. You really need to ask the patient to, look for symptoms and report it as soon as possible before presenting to the hospital with acute decompensated heart failure. Very important about optimization, intensification medical therapy, and finding the barriers and trying to and solve them. However, this always comes with a challenge. Some of the potential challenges include systematic barriers related to awareness from public about, how bad is heart failure, how deadly is heart failure. Some patients don't believe, it's as bad as cancer. And also there are some institutional barriers, in terms of under-appreciating the importance of heart function clinics and the importance of regular follow-ups of such patients to avoid rehospitalization and to decrease their hospital length of stay. We're blessed in our center to have a really good administration who are very supportive for our heart function clinic. One of the barriers, and this is a segue for the second half of my talk, is a virtual heart function clinics. It's a new thing, a new paradigm shift for managing such patients. And I think it's a blessing, alhamdulillah, from COVID-19, is we learned how to really conduct such virtual clinics. This was a statement from the Heart Failure Society of America, published late last year about virtual visits for caring for patients with heart failure in the era of COVID-19 pandemic. Also, there was a statement from the Saudi Heart Association and Saudi Heart Failure Working Group about how to manage such patients during the COVID-19 pandemic by shifting from a physical visit to a telephone visit, assessing patients through the phone, reviewing their medical records and assessing their blood pressure and prescribing their medication. These are the potential benefits that everyone would think, these are the advantage to patients, physician, and healthcare system. With regards to patients, most patients would really love to have easy access with a virtual visit, especially during the COVID-19 pandemic. And if you guys remember, last year at the same time, we were like on complete lockdown. So there was curfew, there was like the patients were not able to reach the hospitals, especially our patients who are really sick and they are at high risk when they come to the hospital to contract COVID-19. So by converting to virtual visit, this was a huge advantage for the patient to have a rapid access to receive a medical advice on time and reduce their exposure to COVID-19 and reduce their stress about contracting the virus. Also very important, involving caregivers by doing it virtually, because most of the time, as I said, most of our populations are elderly. The caregivers most of the time will come with them, but sometimes caregivers have works to do, so sometimes they don't come with them for physical clinics, but doing it virtually, most of the time they will be by their side and they will be able to help delivering the care in a multidisciplinary way. Physicians also are happy because that their patients has been looked after by doing this way virtually, and also reduce their risk of contracting COVID-19 when they don't see patients in person. and they are able to maintain connection between and establish Shabbat between patients and themselves. And most of our patients, we really have great relationship now in a virtual way, to be honest with you, than in a physical way. Also, healthcare resources, doing such virtual visits save the healthcare system a lot, and the patients themselves. And I still remember a patients we are serving from the southern area. And in terms of, we saved her the trip, the cost of the trip, the flight for her and her mother. The patients and her daughter, because she has to come with her daughter. So we saved the trip, the cost of the flight, the cost of the accommodation, and the transportation. And she said to us, by saving this money, I was able to buy interest to an SGLT inhibitor for my mother. So this is a great advantage. However, there are potential challenges to virtual visits. To be able to succeed in conducting such visits, patients must be willing and able to, especially when you have an old people who are not comfortable dealing with a virtual way. But as I said, caregivers can really help in facilitating such visits. Also, the technology must be available and effective, and that's why you have to use devices that's available for everyone. And I think smartphones are available, and especially like WhatsApp and some other ways of communications are the standard of communication for socialization nowadays. Also, one of the potential challenges is inability to perform full physical examination. However, you'll be able to get partial physical examination, including vitals and weight, virtually. Lack of patient-physician interaction, and the touch you have, and the expression from the patients, and that things you're really missing with the virtual visit. And sometimes there are virtual technical difficulties. What we did during the COVID-19 pandemic almost a year ago, especially during the curfew, we converted our landline, the clinic landline, into a WhatsApp account, and we sent it to all of our patients to be able to communicate with us, especially during the time where they were not able to come to the hospital, and they were really afraid of coming to the hospital. And through that WhatsApp, we created a channel of communication between us and our patient, and we start giving them their appointment, and mostly virtual assessment, and scheduling for assessment and medication reconciliation and filling. The virtual assessment consists of evaluating their clinical status, reviewing their medication, especially through WhatsApp. They can send us the pictures and we can see which medication they are taking. And very important for reconciliation, because mostly during the physical visit, most patients don't bring their medication. However, the virtual visit, they just take the picture and they send it to you through WhatsApp or whatever, and you will be able to really reconcile whether what's written in the system is what they are taking in real life. Also, then you can do up titration of GDMT virtually. Counseling is very important and actually very easy to do virtually about medication adherence and diet and exercise. And more recently, we've been doing a lot of counseling about COVID-19 vaccine. We've been receiving a lot of questions whether it's safe or not safe or advisable, and also about medication use during Ramadan fasting. And actually, we were able to send a mass email through WhatsApp to all our patients about how to manage their medication during Ramadan. This is a picture showing what the patients can send us, including their symptoms, their signs, their medication, their vitals, blood pressure, heart rate, and their weight. And and then we review the labs, and then we do refilling of their medication or up titration if needed. And our pharmacy colleagues were really helpful in delivering the drugs to the patient at their home. They don't have to go anywhere, free of charge. And there are 3 ways of communicating with the pharmacy. We learned the hard way. We learned the good and the bad and the ugly. From the left side, you can see this is a patient. In Arabic, is basically saying, المفروض انكم ما يسمونكم عيادة عدم، المفروض يسمونكم عيادة عدم القصور, because the clinic is heart failure clinic, which in Arabic القصور. He's saying انتم ما قصرتوا, يعني it's not a failure, it's actually a success. You get a lot of really praise, alhamdulillah, from patients. الله يقبل دعاءهم. Like you can see that the time of communication, like it's 11:45 p.m. And it's again a challenge to educate the patients to contact you through the regular working hours. This is also one of the good things that we learned. You know, some patients, this is furosemide, which is Lasix. It was labeled by the patients, it's تقوية عضلة القلب, which means strengthen the heart muscle, which is not true. It's another opportunity to educate the patient. This is a water pill. It's not a medication to strengthen the heart muscle. These are the medications that strengthen your heart muscle. For those who have really good sight, you can see this is the same carbon as this one. And this is carvedilol, and this is rivaquilol. Both are carvedilol. When the patient sent us the medication, actually he was taking this from one hospital and this from another hospital, and thoughting that, you know, this is, you know, he thought, no, this is a different drug than this one, where in fact it's the same drugs. Both are carvedilol. I'm just gonna finish up with the case. This is one of my patients, so 49, female with chemotherapy-induced cardiomyopathy, and following her in my cardio-oncology clinic. She developed mild systolic dysfunction. She received FIC-DH chemotherapy, which has anthracycline and Herceptin. Her ejection fraction dropped last year from normal to 40% after receiving the FIC-DH. She's at NYHA function class 2. And I've been following her for up titration until the lockdown happens. So we lost her. But alhamdulillah, I was able to communicate with her through WhatsApp and our high function WhatsApp number. And we were able to, these are the medications she was taking: carvedilol 6.25 and secretive 50 BID before the lockdown. And what do you think? I mean, for time's sake, do you think she's appropriate for virtual clinic visit or not? I think at that time we didn't have an option for in-person visits, so we did a virtual visit. Alhamdulillah, I was able to successfully uptitrate the medication to target dose of carvedilol 25 and secretive 200 BID, and this is her blood pressure after uptitration. And this is her echo after optimization. Alhamdulillah, she returns back to normal LVEF. Last few slides about future direction. 2 trials presented at AHA last year. My Road trial, which is basically a recorded on-demand audio discharge. Basically, they randomized from Cleveland Clinic, randomized 1,000 patients into a usual care before discharge, or a My Road care. Basically, the usual care plus a replayable audio message about instruction, about their medication compliance, about their physical activity, about their fluid and salt restriction. And they followed them 30, 45 days, and 90 days, and 180 days. And as you can see, the active arm, the My Road arm, the people who received the audio message got less ED visit, got less cardiovascular worse outcome, and less cardiovascular death, which means repeated simple messages, just, you know, audio messages sent to the patients, really helped in transitioning the patient from inpatient to outpatient setting. The last trial I'm going to present is EPIC-HF trial, which also was presented at the AHA last year, and it's basically they randomized 300 patients into the, you know, usual care before discharge. And the EPIC-HF active arm, which is basically sending the patients a 3 minutes video this time with, you know, instruction about the same thing: medication compliance and salt restriction and fluid restriction, and a checklist about their medication that's needed in a simple language. And I'm going to show you a picture of this. It's a simple language. It's a water pill. It's a beta blocker. And these are the medication. This is your current dose, and these are the target dose we need you to take. So when the patient comes next time, are they engaged or not? This is the outcome they were looking for. And they asked and surveyed the patients, 70 and 70. They found the video very helpful, and they found it useful in discussing the future plan and why I need to uptitrate the medication to these target dosage. Similarly, the one who received the checklist, they found it like 80 and 70 found it very useful. And the primary outcome was a 20% increase in the active arm, the people who received the messages and the checklist. There was a 20% increase in their uptake in the GDMT, guideline-directed medical therapy with significant p-value. And so in summary, heart failure is a chronic progressive disease with a huge burden on patients and healthcare system. By using a specialized multidisciplinary heart failure program, will substantially improve the patient's outcome through implementing GDMT and patient education, utilizing both physical and virtual care pathways. And patient activation can lead to better engagement and further optimization. I'm gonna introduce طبعا next speaker, دكتورة فخر. She doesn't need an introduction, mashallah. She's a clinical pharmacist at King Fahd Cardiac Center. She's actually the president of the cardio clinical pharmacy group at the Saudi Heart Association. And she's going to talk to us about the essential role of multidisciplinary, the pharmacy, the clinical role of the clinical pharmacist in optimizing heart failure outcomes and treatment. Dr. Fakhr, the stage is yours.
Thank you very much, Dr. Osama, for your great talk. I really enjoyed it. And as you said, being part of this program is very, very enjoyable. Even with the limitations that we are facing, we still are able to find solutions with our great team. I'm sure my other colleagues will introduce the role of other specialty in this program. I would like to focus on a very important thing, is that having a clinic for heart failure was really helpful for us. It really helped us taking care of our patients and also following up with them. Even after that, when it becomes virtual, we were still able to manage and follow the patients. I believe that heart failure does really have a puzzle. What is the piece missing? This depends on each center and each cardiac center around the kingdom. We found our piece. I don't know about other centers, and we are here actually having the opportunity to announce if any of the cardiac centers need our help. We are glad and we are really happy to help you. I believe medication, because of a pharmacy specialty, first of all, and the other thing is that really medication save the heart failure patients, because the other options is transplant or LVADs, which is very hard to do, and it's not an easy process to go through. We believe that heart failure patients are still suboptimal, and it is the leading cause of hospitalization sometimes. And of course, the more hospitalization the patient will suffer, the worsen progression of the disease. We found that almost 50% of the readmission of heart failure could be preventable. And it was just announced by the heart failure registry that was done by the Saudi Heart Association in the kingdom and around the Gulf countries, is that the non-adherence was a very crucial role in admitting the heart failure patients. We have to understand the pathophysiology, not just physicians, also pharmacists, nursing, educators, and dietitians. We have to know that there's a 3 pathophysiology of heart failure. This complexity of the disease is the problem that is really causing us all this dilemma of controlling the patients in the proper way. After we understood all the pathways and all the pathophysiologies and the limitations that we are suffering from, we decided to do our heart failure model, which is the multidisciplinary, as Dr. Osama mentioned, 2017, we start preparing for it. And we started it in a very unique way with the presence of Dr. Walid Al-Habib and the support of Dr. Mustafa Shmeri, which actually they supported this idea and they were able to make a project out of it. And the most important thing is that each one of us should know the role that they have to play in. We will interact with each other, but we will work as a team. We, as a pharmacist, should know that the most important and golden role for the pharmacist is to improve the adherence to the guideline-directed medical therapy. It's not only my role, it's the role of each one of us. To be honest with you, that time we had no guideline for the treatment of heart failure. So we decided to do a national guideline, and it was under the supervision of the Saudi Heart Working Group, under the umbrella of the Saudi Heart Association. We released it by, of course, adopting the international guidelines. And we also study it in our module, so make sure that we are having the most updated medications. And of course, the physicians, the nursing, and the pharmacists should also know the proper medications and the proper outline of each one of them and what's the outcome for each part of the puzzle. On the other side, as Dr. Osama said, we should have a cardiologist to diagnose, but we are working with a team in an endocrine also panel, a nephrologist and family medicine upon request. Of course, the clinical pharmacist and the clinical nurse and clinical dietitian They are with us in the clinic in order to make sure that we are following the golden rule, which is the adherence to the guidelines medication therapy. We have also to have tools for that. We're a human being, and we know that we might miss a piece, we might miss an information, we might just go for a vacation or something. There should be a tool that will improve the adherence of the team themselves to the guideline, and of course, to follow suit with our patients. The guidelines were actually transferred into a checklist tool, and our nurse, Ahmed Hajna, will take us to these tools. And of course, later on, we'll emphasize about each tool and how did we use it. Now, again, for me as a pharmacist, I have to make sure that all my medications are presented here. And if the patient is not on it, why is the patient not on it? And if there is any reason to substitute one with the other, my checklist has to answer all these questions. With the vaccine part, of course, we have to know that influenza vaccine, pneumococcal vaccine also is part of the treatment plan. The pathway is as simple as that. The cardiologist will diagnose the patient and educate them about their disease. The our resident had a very important discussion with the patients, telling them about the disease and what is the goal of having them in this walk-in clinic. And he really helped a lot also in transferring the English to Arabic in a simple language. Our specialized nurse is there also to make our life easy and to start the pathway. And the pharmacist is there also to make sure the medications are available within, of course, the wanted dose. We will talk about it in details after these slides. As I told you, the integration of the heart failure multidisciplinary team is there. And it's according to the need of the patient, because we all know, as we saw from the data before, that your patient doesn't come as a heart failure only. There's always another gift with the patients, diabetes, of course, on the top of them, and the renal, of course, impairment. Now, the consultant, as I told you, they have to listen to the patient and, of course, describe the patient's signs and symptoms to the stage of which heart failure they are in, the GVP, the work, and all these to diagnose them that now they are labeled as heart failure patient. Our heart failure nurse will start the journey by integrating all these data together and giving the appointment to the patients. And more details would be with Mr. Hajna after my talk to tell us about the role of the heart failure nurse in this program. What about pharmacists? I have to make sure that the patients will start the golden medications, which is the RAS system, the beta blockers, and the caregivers has to be educated with the patient themselves. There has to also be labeled for contraindications, for side effects, for cost-effective also is very important, because the more you educate your patients about the proper medications and dosing, the better outcome. And of course, in the end, I have to make sure that all these data is documented, because some patients has a contraindications or allergy or side effects. If we don't document that in the patient's profile, you might commit the same mistake again. This is the algorithm that we are using in the heart failure program, which is the national algorithm all over the kingdom. As you can see now, when I'm talking about the HFrEF patients, it's so clear for me, the systematic pathway that I have to go through. Now, this is my role as a pharmacist, which is up-titrating the target dose. What do I mean by that? It's not just to start the ACE inhibitor. Starting it, like, for example, the Referral 2.5 to 5, this is good to start. But my target dose has to be also achieved. I have to know the initial dose and the target dose of each of the medications my patient's on. Valsartan, for example, we can start with 40 BID, but make sure that your target dose is reached there. Otherwise, you are not giving the optimal benefit of this class of medication. Beta blocker, they are there and they have to be started with the patients, and they are inhibiting of the norepinephrine system, which is important for us to reduce the myocardial oxygen demand. So when I tell this to the patients in a simple way, I make sure that they make their medications the priority for them. They will take it. They will know that if I don't take these medications, I will overload the muscle and I might worsen my case. Again, starting with bisoprolol, for example, 1.25 milligram daily, it doesn't mean this is the proper and your patient is on medication. He has to go to the target dose as much as you can. Aldosterone antagonists, so most of our patients, we are trying our best to cover it as much as we can. Again, we start with low dose, but we have to monitor the patient's kidney function and potassium level. Sacubitril, valsartan now, sometimes we start our patients directly on them. Again, we have to make sure that we start with a low dose, but as much as your patient is able to tolerate, the higher you go, and your target dose would be 200 milligrams twice daily. Ivabradine when needed, and sometimes patients cannot tolerate the beta blocker or they are not controlled with a proper dosing of beta blocker. The add-on would be ivabradine in this case with initiation and proper dosing. Now, these are actually the instructions that we talk to our patients during the clinic. In each medication, I will tell them what to do, when to take it, and what to avoid. The most important thing they have to emphasize on the before meal and after meal. The other thing, what will happen if they get the side effects? For example, furosemide, I know lots of our patients will hate it. And I face it myself. I tell you more than 60% of the patients in the clinic, they refuse to take diuretics because they don't want to go to the WBC. But again, we have to convince them. We have to tell them that you are improving the outcome of your heart, and this will decrease your hospitalization. In this case, they will be convinced and they will make sure they take it on the proper time. All the other medications, because as we said, it's not only heart failure, there's other medications like diabetic medications, thyroid medication, anticoagulants, and so on, has to be explained to the patients properly. We have a checklist for each patient to tell us which medications they are on, even statins, fibrates, and so on. Make sure your patient's checklist is there. Make sure they are on the starting dose, and if they reach the optimal dose, to be labeled that they reached the optimal dose. We had to study also according to the outcome of our program that our adherence to medications has improved from 60 to almost 70% in the first 1 year, which means that we are really doing hard work and we are really doing a good job with the patients, but still our ultimate goal is 100%. Also, we found that this program really improved the patient's quality of life. And after translating the Kansas City questionnaire, which is the one that is used in international studies to study the quality of life of the patients, using the Arabic terms, and of course, a sliding scale to measure the patient's activity and quality of life. And we found that before we start the program, most of the patients has a problem in the walking, the climbing stairs, the jogging, and so on. After going through the program, all of these elements of daily activity has improved. That's not all. The signs and symptoms also improved in those patients. And these are the signs and symptoms of heart failure. The other thing is that they are really accepting the journey of having a heart failure, and they are really improving even in the psychological part, where the depression is really depleted in these patients, and they were able to take this lightly and enjoy their life in a better way. So we believe that the program is important because it will improve the quality of heart failure management. After diagnosing and counseling the patients, the clinic follow-up is very important. Of course, outcome to measure, and the quality of life is an issue for us. There always should be strategies to reduce the heart failure readmission. And as you can see, we have been putting this in colors just to make sure that the ones that would affect the mortality, patients has to be on it unless it's contraindicated. The other ones that will work on the morbidity will be also considered in patients who really need it. Medication and adherence is the problem which we focused on, and we did a Moravsky score measurements for those patients that are visiting our clinic. We are using a MediCoach, which is an application that is built in the patient's mobiles, and it's a very simple and it's a free application. You just download it, you put the name of the medication with the dose and the time to take it. This is how we measured our patients' compliance and adherence. And just to make sure that our audience are really following suit with us, I have this case that I would really like you to answer with me. And this case is a simple 62-year-old man who is with a cardiomyopathy, ejection fraction 30%. Of course, as every hypertension, unless proven otherwise, hypertensive with dyspnea, and they have a lower extremity edema. Now, the weight has been increased in these patients the last 2 weeks. Put this in mind, our audience, because you can see now the gain weight is in a very short time. And since that, the primary physician want to increase the carvedilol dose from 6.25 milligram twice daily to 12.5 twice daily. His other medication is sacubitril twice daily, spironolactone 25, furosemide 80 twice daily orally. And upon admission, his heart rate is 118/82. His heart rate is 88. And the lab work showed for us there is an increase in the BNP, which is uncontrolled heart failure. And the serum creatinine is 1.3. And the other finding is that patients is really suffering from overload. Now, which of the following is the most optimal choice for managing carvedilol at this time? Increase the dose to 25 twice daily, decrease the dose to 6.25 twice daily, discontinue carvedilol, change carvedilol to metoprolol succinate. Please answer the question and let us discuss the proper answer. Increase the dose to 25 twice daily. Well, this is why I'm telling you, I'm emphasizing that the weight of the patient increased within the last 2 weeks. That means patient is wet. When you have a patient who's wet and you increase the beta blocker, the proper thing to do, either you keep it the same or you decrease it. So the proper answer is decreasing the dose to 6.25. That is the proper answer because your patient is wet. We need first to dehydrate the patient and then add the proper beta blocker dose. Okay, the patient will start diuretics. The patient is only a negative of 1 liter for the next 24 hours. Which do you think is the better thing to do for the diuretic effect of the patient? Should we add metalazone 5 milligram orally? Should we add hydrochlorothiazide 50 orally once daily? Or spironolactone 100 milligram once daily orally? Or the butamine 2 microgram per kg minutes intravenously? Now, please think before you answer, because again, these questions are very important to label, because this is where actually is the proper adherence to the guidelines. Again, the patient is on furosemide. He did not achieve the proper loss of fluids, only 1 liter in a 24-hour. So the proper thing to do is either add metalazone or hydrochlorothiazide or spironolactone or dopamine. Wow, majority said, oh no, the majority said spironolactone. The dose is not the proper dose. Otherwise, you're right. We could have introduced spironolactone in this patient, but 100 milligram is not the dose for such a patient. So the proper answer would be metalazone 5 milligram. Thiazides is an option, but in heart failure, it's not the preferred one. And on the other side, he's already on loop diuretics. So metalazone would not be affecting the kidney function for the time being. He's a borderline. So the proper answer would be metalazone. We are almost there. Another one case to go. An old man, 76-year-old, medical history with ischemic cardiomyopathy, ejection fraction 25. So he's a HIFref, hypertension, chronic kidney disease, present to the CCU with a worsened dyspnea and an 8 kilogram weight gain in the past 2 weeks. Again, he's an overload now. And he's running out of his home medication. That gives you a clue that the adherence part with this patient is poor. Or maybe he ran out of the medications and he just got the complications. He was taking aspirin 81 once daily, atorvastatin 40 once daily, lisinopril 20 once daily, metoprolol succinate 100 once daily, spironolactone 25 once daily, and furosemide 40 twice daily. Now, from his vital signs, his blood pressure is 118/68. This number, by the way, is normal in heart failure patients. We see it a lot in the clinic. The heart rate is 76. The sodium is 136. Potassium is 4.8. The serum creatinine is 1.9. And the proBNP is 9,600, which is high. The GVP is 12 centimeter, elevated. And the emergency department received a single bolus dose of intravenous furosemide, 80 milligram. Now, again, what is the appropriate strategy for rapid improvement of his congestive symptoms with furosemide? Do we go with A, which is 40 milligram intravenous twice daily? Or do we go with 80 intravenous twice daily? Or 2.5 milligram per hour intravenous infusion? Or 12.5 milligram per hour intravenous infusion? Again, be careful. There is a study for that. It's the dose trial. It talks about the diuretics in these patients, and it gives us an instructions about the proper dosing for these patients. Again, let us go to the answer. 3, 2, 1. Well, almost there, but okay, we agree that it's supposed to be intravenous, not infusion. So it should be a bolus dose. We all agree on that, and I'm happy to see this answer. But the limiting point here is that he's already on 40 milligram, on 80 milligram. And 40 milligram twice daily orally means that you have to give 2.5 the last dose he took at home, which means 80 milligram intravenous twice daily. This is the proper answer. So when you have a patient who's already on 40 twice daily orally at home, and he came to the emergency and he took a bolus dose of 80 milligram, the next best thing to do is give another 80 milligram IV twice daily is your proper answer. But finally, I'm so happy that my message has been transferred, that it depends on the patient's criteria and outcome. That's why the pharmacist role is important, to educate the patients, the healthcare practitioners, and of course, make sure that they are improving the patient care. We spend a lot of money just to decide about to start a medication, but a little amount of money to when to stop it. Some medications need to be stopped, some medications needs to be started. So please try to do the balance with the pharmacist on board. Make sure that medication errors are really limited and stopped. And thank you very much for having me on this presentation. Now the floor is yours, Dr. Osama.
Wow, that was amazing. Thank you so much for this comprehensive presentation. For the sake of time, I'm just going to move on to the next speaker, Mr. Ahmed Al-Hayajna. He's a nurse practitioner, a nurse specialist at King Fahd Cardiac Center, King Saud University Medical City, and he's going to present to us the role of nurse practitioner, which is a very important role to motive to manage the patients and coordinate their care. Ahmed, the floor is yours.
Assalamu alaikum. Thank you, Dr. Osama, for your nice introduction. تقبل الله طاعتكم في هذا الشهر الفضيل. We are going to have a look at practical tips, a heart failure nurse specialist perspective in heart failure management. Firstly, I want to tell you about the heart failure disease always is associated with the increased morbidity and mortality and reducing quality of life and increasing healthcare costs worldwide. So our goals in the heart failure multidisciplinary team to increase the adherence for guideline directed medical therapy, which is improved. That improves in the heart failure patient outcomes, and also to decrease the cost burden of heart failure patient and improve the quality of life for the heart failure patient. And our vision in the multidisciplinary team, heart failure, to be leading the heart failure program in the region and globally. So briefly, I want to talk about our heart failure program and the team. We established heart failure program in 2014, and in 2014 we bought the clinical practice guideline, and we create the checklist forms, and we build it in the electronic healthcare system in Cerner, which is the discharge and referral and clinic checklist, which is all of this is derived from clinical practice guideline. And the most important, to build a database for the heart failure patient to evaluate and assess your achievement as a team. And also awareness for our staff about the heart failure program, and coordinate the appointments for patients, and establishing the allocation for the clinics. As a multidisciplinary team, heart failure team is covered by Dr. Osama and Dr. Fakhr. All of this team, all our efforts is focusing on the patient care to reach the optimal care for them. And the main role for the multidisciplinary team is the cardiologist, pharmacist, and nurse practitioner or nurse specialist. Other members, they are available upon request if needed to refer to them, like dietitian, rehab, and quality specialist and educator. So there is several studies have shown the importance of the nurse specialist in the multidisciplinary team, heart failure multidisciplinary team. So some our responsibility for in the heart failure program We establish a link between all the multidisciplinary team member and the patient. It's very important, as we can consider it as a maestro in the multidisciplinary team. And also it's very important to follow up the discharge checklist, which is including the all indicators, important indicators included, which derived from clinical practice guideline. And education is very important for the patient and family to increase the compliance patient to the therapy and the follow-up, and giving the patient instruction upon discharge, and explain for the patient about the heart failure, his disease, heart failure in different aspects, and give him the several stages plan, and to let him to understand about his disease. Also, our role in the heart failure multidisciplinary team as a nurse to ensure that discharge instruction is very important, is emphasized to adherence to the guideline directed medical therapy, and also to be sure to give the patient walk-in appointment within 1 to 3 weeks, which is recommended by the guideline, and also establish communication tools to open the channel between heart failure team members and the patient, like WhatsApp hotline and pharmacy applications covered by Dr. Osama and Dr. Fakhr, MediCoach, about the pharmacy application. Other responsibility in the multidisciplinary team in monitoring patient, detect other risk factors, provide education and counseling, and we can help to developing new approaches to decrease hospitalization, which that means reduce morbidities and improving the quality of life. So what's the outcome of our role as a heart failure nurse? Enhancing the effort of cardiologists by reviewing the lab result, by titrating medication according to the guideline, and monitoring hemodynamic status. And triage calls is very important, as covered also by Dr. Osama, receiving the any questions and queries from patient and answering them, and decreasing the hospitalization readmissions. Also, a nurse specialist in multidisciplinary team increase the proper use of evidence-based, we can consider it, and the role of the nurse specialist is very important to integrate heart failure multidisciplinary program with the other medical specialty. It can help to continuous training and motivation, improvement, and evaluation of self-care abilities. So I will show you some our indicators which derived from clinical practice guideline, and using and following this one and assess this one to our achievement. If we are adherent to the guideline, clinical practice guideline or not. Just this is diagram show. Our ACE inhibitor are ARB, ARNI, and beta blocker. We significantly improving. We reach the target and above the target, but unfortunately about the vaccines, we are not reaching the target because this is our hospital stock is not available, and we escalate this issue to the high administration and the quality department. And you can see the readmission within 30 days. If you compare between 2014 and 2020, there's significantly decreased from 15% to 4.3. Okay. And also we can see here improving patient compliance to attending the heart failure clinics. That means about the achievement. That means we are very happy our achievement of multidisciplinary team in the King Fahd Cardiac Center. Just I want to mention some actions we did during the COVID-19 pandemic era. Firstly, we implementing national and international standard precautions for our staff, and activating drive-through for screening of COVID-19, and very important, drug delivery system to the patient, and we are dealing with the other with the transportation companies. Also patient awareness for preventing infection, and we switch the visit clinics to the virtual clinics. This title is covered by Dr. Osama in his session. And we create WhatsApp account to get easy access with the patient, heart failure team, patient to the heart failure team, and to answering all the queries for him. And we can see heart failure ER visit. This diagram, you can it show there is dropping in the ER visit, especially in the 2020 when starting the virtual calling patient and create WhatsApp account is significantly comparing with the 2019 is significantly dropped from 8% to 3%. And thank you very much for all for listening. If any questions.
Thank you very much, Mr. Ahmed, for the very nice talk and informative, right to the point. We are going to make the questions in the end for our audience, just another talk to go through, and then inshallah we'll take all your questions and we will have a very nice discussion. I can see there's a lot of questions coming from our audience, but it's important to introduce our clinical dietitian, my colleague, my friend, and my dear friend, Muna Mabhood. She is a clinical dietitian in King Saud University and King Khalid University Hospital. It's always a pleasure working with her. She really gave us a very nice advice for the patients and for ourselves.
السلام عليكم ورحمة الله وبركاته. مبارك عليكم بكم الشهر. الله يتقبل منا ومنكم يا رب صالح الأعمال. My talk is about how to live with heart failure. I will talk about the role of clinical dietitian for heart failure patients. The primary role of clinical dietitian is to design nutrition program to improve or maintain the health of patients. This program may be short-term or they may be long-term for patients with diabetes, kidney disease, or old age condition that affect proper nutrition. The program designed may be preventive for heart disease, like here in the slide. Like here in slide 22, it's a preventive program. It's talking about the therapeutic lifestyle changes, 7 simple steps for heart health, or in the program that I will talk about here. The program that I will talk about here is the therapeutic one. So the therapeutic to help a patient with heart failure maintain a baseline health and nutrition status. The role includes nutrition assessment, diagnosis, monitoring, intervention, and education called NCB model, which is the nutritional care process of nutrition-related problems in heart failure patients. Heart failure patients require an intensive management with the multidisciplinary team. Attendance at the World Round to facilitate and communicate regarding a nutritional issue, and discharge planning with the treating team. The clinical dietitian plays an integral role the clinical dietitian plays an integral role in the interdisciplinary healthcare team by designing the optimal nutritional prescription that complement drug therapy, physical activity, and behavioral therapy. Based on the patient's treatment plan, other nutrition practice guidelines may be needed in order to provide optimal treatment. Guidelines to characteristics. In 2017, the Academy of Nutrition and Dietetic Evidence Analysis Library update a systemic review of MNT, which is medical nutrition therapy for adults with heart failure. A total of 17 recommendations was developed and have been formulated within the context of the nutrition care process. The focus of this guideline is on dietary and physical activity interventions for heart failure. This guideline is primarily intended for use by clinical dietitians involved in the management and treatment of adults with heart failure. Clinical judgment should be used when evaluating a patient with comorbid condition. It may also be a valuable resource for other healthcare professionals involved in the care and treatment of heart failure. The purpose The purpose, our objective of this guideline is to provide an evidence-based summary of effective practice in the nutrition management of adults with heart failure. The new guidelines focus on an individualizing therapy to reduce heart failure signs and symptoms, prevent hospital readmissions, length of stay, mortality, improve quality of life for the patient, maintaining optimal nutritional status, and increasing patient nutrition knowledge. To whom these guidelines may be applied? This guideline applied to adult heart failure patients in general ward, cardiac center, outpatient clinic, and heart failure clinic. This is the recommendation that I will talk about. Recommendation number 1 from the guidelines is the effectiveness of medical nutrition therapy. The clinical dietitian should provide a medical nutrition therapy to treat heart failure and contributing comorbidities such as hypertension, disorder of lipid metabolism, diabetes mellitus, and obesity. Every patient with a heart failure should have a clear, detailed, and evidence-based plan of care that ensures the achievement of guideline-determined medical therapy, GDMT, this is guideline determined medical therapy goals. Referral to the clinical dietitian for medical nutrition therapy is recommended whenever an individual has heart failure. Then we are enrolled them into the heart failure clinic. Recommendation number 2 and 3 is about frequency and duration of medical nutrition therapy. The frequency and duration of medical nutrition therapy, the clinical dietitian should provide an initial medical nutrition therapy encounter lasting 30 to 60 minutes. Usually this initial visit done before discharging the patient from the ward. With that, with at least 1 to 3 planned follow-up visit encounter 4 to 6 weeks later, and treatment and determine if the patient maybe need another follow-up. Some of them needs to be followed regularly. Research report that this frequency and duration result in a significant decrease in sodium intake, as well as maintenance of serum sodium level, increased exercise tolerance, decreased anxiety, as well as maintenance of body weight. Recommendation number 4 to 8 is about nutrition assessment. So nutrition assessment, in nutrition assessment, we should assess the exercise intolerance as follows. Here, class 1, class 2, 3, and 4. Class 1, no limitation. Class 2, slight limitation with comfortable at rest. The class 3 is marked limitation with comfortable also at rest, but class 4 is unable to carry on any physical activity. Number 2 is about biochemical data. We are talking about the serum electrolyte, blood urine nitrogen, creatinine, lipid profile, fluid balance, and medical tests like echo, medication usage like a herbal supplement, and etc. Also here in nutrition assessment, we are talking about the nutrition focused physical finding. We are measuring the height and weight, body mass index, edema, cachexia, and muscle wasting, hand grip to test the strength of the muscle. Number 4 is about the patient history. We are taking the social history, culture, education level, knowledge, belief, attitude, and others. Other medical or surgical treatment. In the nutrition assessment, also we are talking about the we are assessing the food and nutrition related history. We have to take the full history from the patient about the like a diet history, 24 hours recall, like that. So also we are assessing the allergy. We are taking the food intolerance, altered sense of taste, and etc. Gastrointestinal distress, nausea, vomiting, diarrhea, malabsorption, bloating. Nutrition assessment here, the first is the energy, how to calculate the energy. In assessing energy needs for patients with heart failure, the majority of studies indicate that use of indirect telemetry best determine the energy need. But unfortunately, it's costly and it needs special equipment and time wasting. So we have to go to the estimation. So in the estimation, measuring resting metabolic rate, when indirect telemetry is not available or not possible, considering starting with the usual predictive equation, which is then multiplied by the physical activity. factor to estimate total energy needs. So here the activity factors, sedentary 1 to 1.4, low active 1.4 to 1.6, active 1.6 to 1.9, very active 1.9 to 1.9 to 2.5. So we have to estimate using the 22 kilocalorie per kg per actual body weight for normal nourished patient. Then we have to multiply it by the sedentary or the activity factors. This is for the normally nourished. For the malnourished, 24. For the advanced heart failure is 18 kilocalorie per kg per actual body weight. And then we have to multiply it by the activity factors. Here, the recommendation 9 to 17 is talking about the nutrition intervention. So, nutrition intervention, energy requirement is determined depending on the current weight, activity, and severity of heart failure. Calculation should be based on dry weights. So, typically short-term weight gain of 2 to 4 a pound, about 1 to 2 kg of peripheral for peripheral edema. The clinical dietitian should individualize energy intake also. Protein, here the protein, we have to individualize this protein also. The clinical dietitian should individualize this protein intake, prescribing at least 1 gram protein per kg, but actual body weight per day, in order to preserve their actual body weight and limit the effectiveness of catabolism. In nutrition intervention, sodium and fluid, the clinical dietitian should individualize sodium and fluid intake within the range of 2,000 to 3,000 milligrams sodium per day and 1 to 2 liter fluid per day. Food having high fluid content should be limited. Hydration status must be monitored in terms of weight gain, fluid balance, and electrolytes. Research reports that sodium intake of 2,000 to 3,000 milligram per day and fluid intake of 1 to 2 liter per day result in improvement in quality measures. In potassium, some diuretics may be increased or may increase the potassium excretion. Potassium supplement or high potassium diet is necessary in some cases. Other dietary considerations, stimulants intake should be reduced or eliminated. Coffee-containing drink and gas-forming food. Serve small, frequent meal. 5 serving of fruit and vegetable also it's recommended. In case of inadequate oral intake, the use of high-calorie and high-protein nutritional supplements are recommended. For severe malnourished patient with low food intake, enteral feeding or TBN may be considered. The clinical dietitian should encourage an individualized physical activity plan. The clinical dietitian also should educate on self-care on topics such as energy and protein intake, sodium and fluid intake, physical activity, self-monitoring. Adults with heart failure should receive specific education to facilitate heart failure. Before discharging the heart failure patient home, my rule is to meet them at the bedside. I spent a great deal of time with them talking about their sodium and fluid restriction. Sodium and fluid is the diet is really important part of heart failure patient region. To keep that under control, I really go into details and trying to develop a personalized and individualized plan of care for each patient. The clinical dietitian here intervention is had to implement the medical nutrition therapy and updated regularly. The clinical dietitian should consult with others on the interdisciplinary healthcare team regarding the vitamins, minerals, and herbal supplementation due to there are many interactions between various supplements and common medication. The clinical dietitian should monitor and evaluate the exercise, biochemical data, and nutrition focused physical finding, patient history, food and nutrition-related history. Finally, heart failure is a chronic disease. It's chronic illness that can be managed by a medication, diet, and lifestyle changes. Patients with heart failure can have many good days, but then they can collapse and have several bad days. Our goal is to manage these relapses and to prevent the hospital readmission. Thank you.
Thank you very much, Mrs. Muna, and it is a great talk with very important messages for our healthcare practitioners. Dr. Usama, you can see that there's a lot of question here.
I agree, and we have lots of time.
And we can ask Knut
Agree.
Retaj to give us another maybe 10-15 minutes just to answer the pool of questions that are very important to answer. If we get the approval from Knut Retaj.
I think we can answer them quickly. I mean, some of the questions are like 1 minute question, hopefully.
Okay,
so
go ahead.
Starting with the first one, Dr. Faiz. So Dr. Mustafa is asking about the cardiorenal syndrome. Is it true or not?
Actually,
less than 1 minute.
Yeah, this is need a lecture to talk about cardiorenal. We know 5 types of cardiorenal syndrome, and this is a major hassle if we have a renal dysfunction, especially if the creatinine less than 30. You cannot give a lot of medication. You cannot give ARNI. You cannot give SGLT2 inhibitor. You can sometimes you need to intensify the diuretic to maximum tolerated dose, and you go for ultrafiltration. So the kidney function is very important, and you know that the kidney worsening caused by 2 things: either hypoperfusion or congestion, and that's why you have to balance the hypoperfusion and congestion. And when you start your medication, you know that your creatinine goes little bit high, just improving, then go a little bit high, but you continue on your medication. So that's why you need the heart failure specialist to just go through. And we know that about 50% of our patients is seen by nephrologists. That's why sometimes we recommend that the nephrologist could do once weekly round on our patients, because we are giving some drugs which might cause more dehydration and cause more damage to the kidney if it is increasing. That's why fine-tuning is very important. Follow-up kidney function is very important, and go through their guidelines. And actually, we have a very good team, nephrology team in our institute and in the university, and they are managing this type of patients very nicely, especially if they have worsened kidney function or hyponatremia or hypernatremia or whatever. So this is an important point and very risky situation, and usually the complication rate is very high in that group of patients, and they die. The mortality rate is higher. And that's why this is things we need.
Dr. Faiz, قلنا يبغى لها lecture لوحدها, بس I totally agree with you. It's there. There are 5 types of cardiorenal syndromes. It's very prevalent in our populations زي ما تفضلت, and definitely needs attention, especially it's interfere with our management. وفي واحد من الأسئلة حيجي عليه بعد شوي عن CKD. السؤال الثاني, can we start ARNI in patients with blood pressure, systolic blood pressure of 90 millimeter mercury? Dr. Fakhr?
Yes, as we know that in heart failure patients, usually the blood pressure reading is not as the normal reading. So 90 for us is a good number. As far as your patient is tolerating the low dose, we can start and monitor, of course. And it depends on the signs and symptoms of the patients, if they are developing hypotension or not. Otherwise, it's not a limiting point. We can.
Yeah, I agree. And then Prof. Mustafa Shmeri asking, what's the role of ARNI in African American?
This is for you, Dr. Usama.
Sure. So as far as I know, there is no difference. Actually, there was a subgroup analysis of either the Pioneer or Transition HF trial that showed patients, African American or white, there was no difference. The ARNI was able to reduce the proPNP in both populations, whether they are white or African American. So it's good for all. Good.
Great.
Next, in patients with conventional therapy, I want to add more drugs. Should I start a SGLT inhibitor or an ARNI? Very good question. Definitely Dr. Faiz, because this is the updated guideline.
Yeah, this is 2 different classes. You know, this is SGLT2 is a diuretic, more accurate than natriuretic. and it decreases preload, decreases afterload, decreases fibrosis, and decreases blood pressure, and decreases weight, a lot of things. So this is as an addition to diuretics or just a replacement of diuretic. But the ARNI is one of the main pillar of the medication, so you have to start it as in the first line of treatment, ARNI or S inhibitor or ARB, beta blocker, and then diuretic. At that stage, you can replace or decrease dose of diuretics and add SGLT2 inhibition. So the treatment of SGLT2 on top of ARNI. So if I were the one, I will start the ARNI first.
Especially, I think, yeah, Dr. go ahead.
Go ahead.
Especially when you have a naive patients. I mean, patients who are not diabetic with heart failure. Maybe this is not the area of discussion in this webinar, but if you have a patient who's already diabetic and he has a heart failure, so starting either or, but we still need both of them in some of the patients.
Yeah, and it works a different mechanism of action, so you can use this and that, and simultaneous use actually was better than subsequent use. I would use it. Next question for the sake of time, what's the update on ARNI and HFpEF? Prof. Mustafa, this needs another lecture, wallah. But briefly, Dr. Faiz.
Yes.
You are the godfather of the HFpEF.
No, yes, it is. Paragon trial showed misses the statistical significance of mortality, but decrease in hospitalization. And you can give it for the ejection fraction up to 57%. That's why now they extend the use of ARNI up to the mildly reduced up to about 50% or more, but not more than 57% in female, but not more than 50 in male. That's why, yes, there is the Saudi FDA will just approve this and just extension of indication of the secretory valsartan up to the 50% and mildly reduced. But in patient who had heart failure with preserved ejection fraction more than 60, still there is a lot of studies going on and still not indicated by guidelines. However, if you ask me, it can be used. Yes, it can be used because patients, some of them are getting improved, but we need an evidence. There is no strong evidence for that. The evidence is still weak.
Yeah, that's زي ما تفضلت يبغى له ويبينار لوحده الHFpEF management and use an ARNI. Next question by the board, Dr. Prof. Mustafa. What are the activities of KFCC at home care? I think that was covered by me and Ahmed. And what the outcome on rehospitalization mortality. So basically, I will let Ahmed answer.
Yes, Doctor, about the activities about the home care, as I mentioned in my session, we establish communication tools with the patient to let the patient to get easy with us, like WhatsApp, through hotline, and also the pharmacy application by Dr. Fakhr Medicoach. Everything very important about the WhatsApp. The patient, they can contact us and they're asking about queries and we answering them and decreasing the ER visit also. As I show in my session, decreasing the ER visit. So this is the way we are doing as communicate with the patient through WhatsApp and the hotlines.
I think, Sir Usama, there is a part 2 for also Ahmed. They're telling us what is the first thing a nurse do when a patient has a symptoms of heart failure after admission to the hospital. So this is also for Ahmed.
Firstly, we have to assess the patient if needed. He receiving the proper medication, he receiving the good education, he receiving following the checklist about the admission, the standardized of the admission. According to the guidelines, this is the first rule of as a nurse for the patient admitted as a heart failure. Should be following the standardized of checklist, medication, education, everything.
Yeah, answering the first question also. So Ahmed showed the graph of emergency visit that was decreased in 2020. And part of this because of the virtual visit and part of it could be because of fear from COVID-19. But definitely from other, there was a pilot clinical trial using virtual visit versus standard visit or physical visit, and there was definitely decrease in ED visits and no-show rates, as Ahmed also demonstrated. Our no-show rate has increased in 2020 as well because of the use of virtual visits. But definitely virtual visit has improved compliance and no-show rates as well. Then again, Prof. Mustafa asked how you found the difference between brands and generic. He's asking very good questions, honest to God. But كل question هذه, I would leave it to Dr. Fakhr to give us another webinars about these things. Wallah, it deserves another webinar.
It's always a pleasure, of course, talking about generic and brand pharmacy and the medications. And for sure, we will conduct, inshallah, very soon a webinar talking about our experience in brand and generic. And we all know that it's called pharmacovigilance. The Saudi FDA has a very nice role all over the kingdom talking about the difference, and the APA, which is the active product index in each medication. We all face that some medications are not working with the patient. And we had some cases who had be admitted to the hospital because of some diuretics are not working, some proton pump inhibitor is not doing a good job, and so on. So sure, we'll promise our audience that we'll have a pharmacovigilance webinar. Our physicians are invited, our nurse also, and our dietitian to also tell us your experience and how to report it so that we can stop these medications from the market and withdraw it so the patients will not be harmed.
Great. Another question about the role of pharmacists in cost effectiveness in heart failure management.
Well, the role of pharmacists is, again, it's a teamwork. I believe in that. And I always say there's no something called a one-man show. It's never the case. We always have to work as a team. Pharmacist has a very important role, first of all, in making the medications available. So our colleagues in the store are very important. Our colleagues in the inpatients and outpatient are very important also for dispensing and counseling. Our also colleagues in the street pharmacy, the community pharmacy, they should also be involved in the instructions and education of the patients and their healthcare, also taking care of them. And of course, our pharmacists in the clinic. So we all work together as a pharmacist in different field and with the physicians and nursing, because we are there to make this complex, which is heart failure complex, simplified, and to reach to the end of the journey with our patients with a healthy life and a healthy heart.
Great. Last question. Again, clear threshold or cutoff of serum creatinine or EGFR that you have to discontinue ARNI or downgrade ARNI. If there's worsening of kidney function or increase more than 30% serum creatinine, the indication discontinue medication in the case of ACE and ARBs. So basically, you start the patients on ARNI or ACE or ARBs, and there's deterioration of kidney function beyond the 30% that's expected. What to do? I guess Dr. Faiz want to answer this question.
Yes, the EGFR less than 30 is the cutoff for the starting ARNI, and the other contraindication for ARNI or not of the precautions. If the patient had liver cell failure more than child B, or hypotension or hyperkalemia, also this is one to have to look at it. Yes, the Entresto or the circulatory valsartan. If you have an acute rise like this, it is an acute on top of chronic. So at that time, I think you have to reduce the dose to the minimum dose, which is 50 milligram BID, and follow up this patient as soon as possible. Because each titration or each stage of changing the medication, you have to see the patient in 1 or 2 weeks, as we do usually in our walk-in clinic.
Agree. And another practical tips is when you use ARNI in a patient who's euvolemic, as you know, it has natriuresis because of the neprilysin inhibitor. You might need to decrease the dose of Lasix. And most of the patients we see either with hypotension after starting ARNI or with acute kidney injury, most of the time is pre-renal because of over-diuresis, because you're adding a drug that diurese on top of already patient taking baseline Lasix dose. So my advice is usually to, if they are hypervolemic, that's easy. If they are euvolemic, we might need to decrease the dose of Lasix. Great, we finished all the questions in less than 10 minutes.
Just one more comment. The cost effective is the role of pharmacists. So I'm really from this webinar inviting all our pharmacists in order to join with us in our coming project, which is the cost effectiveness of the sacubitril valsartan in the management of heart failure. So please contact the Saudi Heart Association, the Saudi Pharmacy Group, for being part of this research. We are glad to announce that the HTA unit, which has been approved to be part of the Saudi Heart, in order to calculate the cost of the medications versus the cost effective of the admission and so on. So please be our guest. The other thing is that the future of this project, we are heading now towards the nationality, which is the nationwide program, with the lead, of course, of Dr. Osama Al-Mikbil. We are looking for also nationalizing this program, making the outreach for all over the centers around the kingdom and the Gulf countries. We are not, of course, away from international also programs. We are always trying to get the data as similar as the international data when we already achieved part of it. But a little comment, Mrs. Mona, we saw a lot of banana in your presentation. And you know, banana has a lot of potassium. So is this because you want to tell that the patient should not take a lot of banana during their management, or what's your message?
No. We have to monitor the electrolyte like potassium, sodium, like daily. But the bananas, contain potassium. We have to not avoid banana for any patient with heart failure or even with a kidney disease. We have to teach them how to limit the banana, like any kind of a fruit, how to limit their intake. We have to put a plan for them, not to avoid all the fruit, because it's containing vitamins and all good things. But we have to guide them how to choose the right food.
Great. So any message, Dr. Osama and our colleagues, before we end up this webinar?
No, thanks everyone. Allah yatikum al-afiyah, for the speaker for being on time, for the attendee for really raising a very important question that opened doors for more actually webinars and discussion. And I really enjoyed it myself. It was really great webinars, and hopefully the attendee also felt the same. Inshallah, la yanfa bil jami' bi'ilmahum. Thanks for the speakers, and thanks Dr. Fakhar for organizing this, and thanks Novartis for sponsoring such events, Saudi Heart as well.
Thank you very much, everybody. And this webinar is recorded, and you will find it on the site of the scope, which is under the Saudi Heart. It's recorded and it's there for all the people who asked for the references. And thank you so much for our Kunuz which really did a great job with us tonight. We will have you very soon in our coming webinar, and see you tomorrow, inshallah, in the atherosclerosis. Thank you so much, everybody.